Good evening, everyone, and welcome to the October 21st edition of CAEP's National Grand Rounds. My name is Justin Yan, and I'm an emergency physician and researcher at Western University in London, Ontario. As the abstract competition representative and co-chair of the research track at this past year's unfortunately canceled CAEP conference in Ottawa, I'm thrilled to moderate tonight's rounds, CAEP Research Plenary, the best in Canadian EM research, the top 4 abstracts. On behalf of the CAEP Research Committee, I'd like to take a moment just to acknowledge all the reviewers listed here who volunteered their time to score grant applications and abstracts in last year's competitions. The committee is also incredibly grateful and indebted to Shanna Scarrow and Kelly Wyatt from the CAEP head office for their hard work in making everything run smoothly for both the grant and abstract competitions. We'd also like to take a few minutes at the beginning of this presentation to acknowledge the 2019 and 2020 CAEP grant awardees. Our junior investigator grant winners, Dr. Ariane Boutin, Dr. Shannon Fernando, Dr. Quinton Patterson, and Dr. Rebecca Shaunup. Our CWIPS grant winners, Dr. Sahil Gupta and Dr. Ahmed Taher. Our CAEP CanVector grant award winner, Dr. Federico Germini. Our CAEP Stremi Grant Award winners, Dr. Lauren Costello and Dr. Jessica Moe. And finally, our EM Advancement Fund grant winners, Dr. Teresa Chan and Dr. Christian Yadav. Congratulations to all our grant winners. To continue supporting Canadian EM research and future grant winners, please consider donating to CAEP's Emergency Medicine Advancement Fund. This year, without fundraising events like Docs That Rock, we are very much in need of generous donors to the EMAF. 100% of funds go directly toward research and all donations are tax deductible. For more information, please check out this website at the bottom here. We'd also like to take a few minutes to acknowledge the 2020 Abstract Award winners, since we weren't able to do that at this year's CAEP. For those wishing to read the abstracts of the winners or any of the published abstracts from this past year's competition, you can use this QR code to access the CGEM supplement. Our winners of the resident research abstracts, Dr. Hussein Al-Ramawi, Dr. Gregory Beller, Dr. Shannon Fernando, Dr. Michael Hale, Dr. Irfan Hatem, Dr. Justin Coe, and Dr. Patrice Patton. Our top Education Innovation Abstract Award was a tie and went to Dr. Stephen Friedman and Mr. Ben Forrestal. Our Choosing Wisely Canada Abstract Award winners, Mr. Samuel Thibault and Dr. Sunil Upati. Our CAEP CanVector Research Abstract Award winners, Dr. Leila Salehi and Dr. Samir Sharif. Our top CWIPS Abstract Award went to Dr. Jesse McLaren. Our top pediatric abstract went to Dr. Samina Ali. And our top resident research abstract award went to Dr. Michael Davison. The next 4 abstracts are why you're all here tonight, and we'll present their research in reverse order of what I have here. Our presenters will have a maximum of 10 minutes to present their abstracts with 2 to 3 minutes for questions. Please keep in mind I will have to be strict with time in order to allow everyone to have enough time to present. So our top new investigator award and 4th plenary presentation is Dr. Catherine Varner. Our top medical student research abstract award and 3rd plenary presentation is Mr. Brenton Wong. Our 2nd plenary presentation is Dr. Sheldon Cheskis. And our Grant Innes Research Paper and Presentation Award and 1st plenary presentation goes to Dr. Ian Steele. Before the presentations, one friendly reminder about this year's dates for the abstract and grant competitions. This year, our abstract competition opens in a week and closes December 11th, with notifications by March 2021. Our grant competition this year is taking place after the abstract competition and opens in February, closing in mid-March. For more information, please look at the website at caep.ca/research. Without further ado, I'd like to introduce our first speaker, Dr. Ian Steele. Dr. Steele is a clinical epidemiologist and an emergency physician with a focus on health services research in EM. He's internationally recognized for his clinical research in emergency care. Dr. Steele was the first chair of the Department of EM at U Ottawa and has since developed this into one of the most productive EM units in Canada. He was the inaugural chair for the academic section for CAEP and the current editor-in-chief of the Canadian Journal of Emergency Medicine. Dr. Steele will be presenting his abstract, A Cluster Randomized Trial to Increase Rapid Use of Cardioversion for Acute Atrial Fibrillation and Flutter.
Hello, everyone, and thank you for tuning in to watch our CAEP abstract presentation. I want to acknowledge the many co-investigators who've helped with the study, which was conducted by the Department of Emergency Medicine at the University of Ottawa. It was funded by the Cardiac Arrhythmia Network of Canada, and we have no conflicts to declare. Acute onset atrial fibrillation or flutter is the most common arrhythmia treated in the emergency department, and we're focused on symptomatic acute onset episodes of AF or a flutter where cardioversion is an option. Typically, the onset's less than 48 hours, but it may be less than 7 days if the patient's anticoagulated. There are two treatment approaches, early or delayed rhythm control, but we know that many Canadian emergency physicians definitely prefer early cardioversion. In 2018, CGM published the CAEP Acute Atrial Fibrillation Flutter Best Practices checklist, and we recommended early rhythm control by shock or drug, as well as stroke prevention by judicious use of oral anticoagulants. The overall goal of our trial was to safely decrease length of stay by implementing the CAEP AAFF guidelines. Specific objectives were to design an active knowledge translation implementation strategy, conduct an implementation trial to evaluate effectiveness in reducing length of stay, and to evaluate secondary outcomes such as use of rhythm control, use of oral anticoagulants, and adverse events. We conducted a pragmatic step wedge cluster randomized trial at 11 Canadian community and teaching hospital emergency departments. We enrolled consecutive stable patients presenting with AAFF and excluded those with permanent AF who were unstable or were sick with other medical issues. Our primary outcome was length of stay in minutes from arrival to disposition. And the primary analysis was a linear mixed effects regression accounting for the step wedge design. Our study sites, you'll see the coordinating center in Ottawa and 11 emergency departments in 5 provinces from Saskatchewan to Nova Scotia. I'm going to give you a schema of a step wedge design with the steps on the left side in the months across the top. You can see in the first month, all sites are in the control phase. The second month, the first site goes into run-in period. In the 4th month, that site goes into the intervention period, and this continues until the end of the study when all sites are in the intervention period. We employed a number of different knowledge translation implementation strategies, including conducting qualitative interviews of stakeholders, identifying local champions, and developing local implementation committees with representation from physician group, nursing, pharmacy. We made a special effort to engage the cardiology groups at each hospital, and live presentations were made at each site by the PI. The champions gave ongoing feedback to physicians throughout the study. In addition, we developed several learning tools, including online teaching slides, as well as smartphone app, and these are available in both official languages at the sites that I show on the slide. The messages that we tried to emphasize for the doctors were: cardiovert yourself with drugs or shock, do not call cardiology, do not order troponin, try to send the patient home in less than 6 hours, and prescribe oral anticoagulants if the patient's CHAD65 positive. We screened over 6,000 patients eventually enrolling 844. None were lost to follow-up. 126 were in the run-in period, and final primary analysis looked at 718 cases. The patient characteristics of subjects in the control and the intervention periods were very similar, with the majority having an onset of less than 12 hours and having had a previous episode of AF, and the majority presented in atrial fibrillation. This is a somewhat complicated slide which shows the mean lengths of stay at each site. On the left side, 11 sites in the 14 months of the study across the top. The blue is the control period, gray run-in, and the golden is the intervention periods. And the most important observation here is the significant variation in mean lengths of stay for each site, as you can see on the right side there. And this was partly due to the fact that in the Quebec sites, the cardiologist services tended to want to keep the patient overnight and be assessed the next day, even though they had already been cardioverted by the ED staff. This shows the primary analysis, and we had a relative reduction of 18% in length of stay with an associated p-value of 0.048, and that p-value led to a minor celebration by the investigating team. Here we see the adjusted odds ratios for secondary outcomes in the emergency department. Use of rhythm control meds, electrical cardioversion increased, but not significantly after adjustment. Use of rate control meds dropped very significantly, and there was no change in the proportion of patients who were discharged home. Looking at other interesting outcomes, the proportion who ended up in sinus rhythm in the ED increased by about 10%. Use of consultations was reduced by 10%, and the total proportion of patients on OAC at discharge, if they were CHAD65 positive, went up substantially. Adverse events in the ED were relatively uncommon, whether associated with the infusion or with the electrical cardioversion. At 14-day follow-up, we had no deaths and no strokes, and a small number of patients who had undergone subsequent electrical cardioversion. So we successfully completed a stepwise trial of 844 patients, 11 emergency departments in 5 provinces. We employed a variety of implementation strategies to overcome significant barriers, reduce length of stay by 1 3/4 hours, increase use of antiarrhythmic drugs and electrical cardioversion with no increase in adverse events. The implication of our study that clearly cardiology service is sometimes a barrier to early discharge, particularly in Quebec, that a multimodal implementation plan can significantly change behavior in Canadian emergency departments, and we encourage use of local champions as well as use of the app and the teaching slides. The CAEP AAFF best practices checklist is a very solid reference for emergency physicians. And early cardioversion and discharge, while being the norm in Canada, is not generally used anywhere else in the world. A few limitations. The qualitative interviews did not identify the barriers posed by the cardiology services. Extreme lengths of stay had not been anticipated, and possible unknown consequences may have occurred for patients who were excluded from the study. So in conclusion, this step wedge randomized trial successfully implemented the CAEP AAF best practices checklist, and the trial led to significant changes in care of these patients with decreased lengths of stay, increased cardioversions by drug or electricity, and no increase in adverse events. And the bottom line is that early cardioversion allows acute atrial fib and flutter patients to quickly resume normal activities. I want to give a big shout out to the many team members in Ottawa and at the 11 sites. We could not have done the study without you, so thank you very much. And at this point, if I have any time left, I'm more than happy to take some questions.
Fantastic, Ian. Thank you so much for the presentation. You do actually have a couple minutes of time for some questions. So
Okay, can we remove the slides then?
So Ian, the first question comes from Allison. And what Allison wants to know is, what's the advantage of using a step wedge design? Why did you choose to use a step wedge in this case?
Yeah, that's a really good question. And the advantage of that is that you go forward with it, bringing in a new way of doing things, but you can't go back. So we had such a complicated implementation strategy with all the various modalities, basically training the team to cardiovert early and send home early. So if you've done a standard randomized trial, you would lose a lot of power. Half the sites wouldn't do anything. If you've done a crossover trial, it's virtually impossible to go back. So the step wedge is a very elegant way of implementing new QI or policies in a hospital.
Yeah, my understanding, Ian, is that it's the preferred way, particularly for like knowledge translation strategies, where it's a huge intervention and often a multifaceted intervention that needs to be implemented across sites as well.
Exactly.
A secondary question, Ian, one that I have for you. This obviously required a ton of work. How difficult was it to convince emergency physicians and nurses and cardiologists? Cardiologists are the ones I'm really looking at, but how did you convince them to comply with the guidelines?
Well, I explained all the things that we did, but it was incredibly frustrating, and we would have to follow up some of the sites on a regular basis. Some adopted it pretty easily, but some sites, there were just these endless barriers, doctors that were just not used to cardioverting, or they thought it was too aggressive. And as I mentioned a couple times, the cardiology services had this strange way of doing things where they absolutely had to see the patient, even though they'd been cardioverted. So I think changing like the local culture is not easy.
Absolutely. Well, thank you very much, Ian. That's all the time we have for you. We really appreciate your presentation. So thank you.
Thanks, everybody.
Okay. Next presentation is from Dr. Sheldon Cheskis. Dr. Cheskis is an associate professor with the Division of Emergency Medicine, Department of Family and Community Medicine at the University of Toronto. He's a scientist at the Li Ka-shing Knowledge Institute at St. Michael's Hospital in Toronto. He's the medical director for the regions of Halton and Peel with the Sunnybrook Center for Pre-Hospital Medicine. As if that weren't enough for Sheldon to do, he's also one of the principal investigators for CANROC, or the Canadian Resuscitation Outcomes Consortium, and he is a recognized international authority in the area of CPR quality and out-hospital cardiac arrest resuscitation. Sheldon has published over 100 manuscripts in high-impact journals such as the New England Journal of Medicine, Circulation, CMAJ, and Resuscitation, and all of these have changed resuscitation practice around the world. Sheldon, or Dr. Cheskis, he will be presenting double sequential external defibrillation for refractory ventricular fibrillation, the DOSE VF pilot RCT. So take it away, Sheldon.
Yes, and thank you so much for those kind words. Thank you to CAEP for allowing me to present our work on the DOSE VF pilot RCT. The following is my conflict of interest slide and my research funding slide. Up front, I'd like to thank my co-investigators and collaborators, but more so the 2,500 paramedics we taught the DOSE VF protocol to. Without the work of the paramedics, I would not be here speaking tonight. So a huge shout out to all the paramedics who were involved in this study. Let's take a look at a clinical vignette from the DOSE VF pilot RCT. So 70-year-old male, history of coronary artery disease, sudden onset of chest pain, shortness of breath, and goes into cardiac arrest with a presenting rhythm of VF. So here you'll see shock 1 with pads in the AA position. You'll see shock 2, the VF waveform, almost not changing. Shock 3, it's as if defibrillation never occurred. The first double sequential shock, a return of spontaneous circulation, and everyone goes home happily ever after. So what is this about, double sequential external defibrillation? So what this is the use of 2 defibrillators, one with pads in the AA position, a second with pads in the AP position, and sequentially or simultaneously shocking with the use of two defibrillators. And why is this of so much interest right now? Well, we know that many patients remain in VF after multiple defibrillation attempts. While defibrillation transiently terminates VF in many patients, refibrillation is incredibly common. Double sequential and vector change defibrillation have both been proposed as alternative therapeutic strategies for refractory VF. Previous research has produced inconclusive results with no control of timing of double sequential or the CPR quality provided. In essence, double sequential is being used as a last-ditch effort when everything else fails. To date, there's been no high-quality evidence by way of an RCT to support or refute the use of double sequential for refractory VF. The aim and therefore objective of our study was to determine the feasibility, safety, and sample size required for a 3-arm cluster randomized trial with crossover, comparing double sequential or vector change to standard defibrillations for patients experiencing refractory VF. So if we look at the 50,000-foot overview of our study design, we wanted to focus both on the vector and the energy. The reason being both have been proposed as a mechanism by which double sequential may be effective. Patients had to present in VF, receive standard therapy, and have a minimum of 3 consecutive AA shocks that failed to terminate VF, after which time they're then randomized to current practice, which would be continued AA defibrillation, or an intervention arm of vector change defibrillation, changing paths from AA to AP position and continued shocking in AP position, or the third intervention arm of double sequential external defibrillation. The pilot RCT design was cluster randomized with crossover predetermined intervals. We did this at a level of 6 months with randomization at the level of the service, so the service served as a cluster. This is a technique we've used in multiple RCTs and the Resuscitation Outcomes Consortium. The medics love it because they know what they're doing for that 6-month period of time, after which they cross over to an alternative therapy. There's no envelopes, there's no confusion, and the medics like that process. 4 services, 2,500 paramedics chart this particular protocol. The protocol was done as a feasibility pilot. And why did we do it this way? Well, many people would say you do a pre-hospital study, 3 arms, cluster crossover, with 1 arm that requires 2 defibrillators. Many people say there's no way you can do that study. So we wanted to make sure that randomization could be maintained, you could adhere to the protocol, we could recruit enough patients, ability to obtain outcomes, and the ability to change with respect to our protocol by learning from the feasibility pilot. We ran this as an internal pilot, which oftentimes forms the first part of the definitive trial. The data is often included in the definitive trial, and the advantages are preserving efficiency in trial design. If you do an internal pilot with no signal for benefit, why go on to the more expensive randomized controlled trial? Our a priori feasibility outcomes were to ensure 80% of patients received treatment as randomized, 80% of patients receive an intervention shock prior to shock 6. Our secondary outcomes were ROSC, VF termination after a single or multiple shocks. With the primary analysis as intention to treat, we actually performed 3 additional analyses as well. We also wanted to look at safety. We wanted to look at defibrillator damage due to the concerns expressed by some of the defibrillator manufacturers. Burns, intermittent shocks provided, injuries to patient bystanders or paramedics, and concerns of paramedics or ED staff with our study protocol. We began in March 2018. We went for 18 months to September 2019, 4 sites, 152 patients, randomized in cluster fashion, exactly similar to the RCT. If we look at the Epstein characteristics, we see no significant difference in any arm with respect to these variables, an incredibly high rate of bystander CPR in the sites, and a huge call out to those communities producing such high rates of bystander CPR. Talk about the paramedics, look at the CPR quality across all these arms. All are guideline compliant with respect to CPR quality. The CPR fractions in vector change and double sequential are superb, considering an intervention had to be done to actually maintain those CPR quality fractions. So super job was done there. If we look at drug giving, amiodarone, epinephrine, no differences in any of the arms with respect to amount of drug given. If we look at our feasibility outcomes, 90% of patients received treatment as randomized, easily surpassing our feasibility outcome for this particular variable. Again, superb work, but look at this. 93.3% of patients got shocks prior to shock 6, which is an incredible comment on the work that the paramedics did. Here, I get excited about those who got it at shock 3. Our paramedics were so excited, they wanted to give electricity as quickly as possible. If we look at here enrollment, it varies depending on the size of the service as well as the rate of refractory VF in those particular jurisdictions. In our pilot study, there were no chest burns, no defibrillator damage, no inadvertent shocking of rescuers, and no complaints by paramedics or staff. In fact, many emergers looked at implementing a double sequential protocol. I can tell you right now, in our work prior to the pilot study, in the pilot study, and in the randomized trial, we have never damaged a defibrillator using our technique of sequential defibrillation. The study finding that has garnered the most interest is the ITT outcomes with respect to VF termination and ROSC, where we see greater rates of VF termination and ROSC at vector change and double sequential compared to standard care. ROSC rate at ED arrival did drop a significant amount in the vector change arm, as we did see a higher rate of rearrest. By way of discussion, this is the only trial to date assessing the impact of alternative defibrillation strategies in refractory VF. We differ greatly from previous observational work by using randomization with cluster crossover in both rural and urban settings. We controlled our timing of the shocks, we provided high quality CPR, and there was a high level of medical oversight, a call out to Mike Feldman, Rick Verbeek. Everyone gave feedback to the paramedics, which really enabled us to keep the interest in this study. Our feasibility, sample size, and safety objectives were all achieved. Our limitations were a lower number of patients in the standard arm due to the largest agency randomization schedule, but in cluster randomization that all balances out. And if we look at our pilot plus the RCT to date, each arm is almost exactly the same in size. Only Zoll defibrillators were used in double sequential during the pilot, but we're using LifePak defibrillators currently. Predominantly urban centers enrolled, but rural centers are currently enrolling. The high level of paramedic interest and medical oversight may not be replicated in other areas. One area that we made a change was in the inclusion of fire shocks. So we know that the benefit of double sequential is greatest when it's done early. In the pilot study, we did not include fire first responder shocks, yet 30% of patients had these shocks, which had the impact of delaying intervention, such as vector change or double sequential. In those cases, we feel this may have been a potential to underestimate the effect size of the intervention. Currently in the randomized trial, fire shocks are counted, and we'll see the impact of that on our findings. Our randomized trial began in September. We were really excited to add the Middlesex London service. Next month, we'll be adding the Ottawa Paramedic Service, and we're really excited about adding those agencies. The primary outcome of survival hospital discharge for the randomized trial, 930 patients enrolled over 3 years, inclusive of the internal pilot. In conclusion, the DOSE-VF pilot RCT demonstrated that the protocol is feasible as well as safe. VF termination and ROSC were greater in double sequential and vector change compared to the standard care, and the primary outcome of the DOSE-VF RCT will be survival hospital discharge based on the pilot RCT findings. I thank you for your time and happy to answer any questions.
Thank you, Sheldon. That's excellent work and very, very interesting as well. One question that came up is, can you tell us a little bit about how the pilot protocol may have impacted the current RCT? Like, how have there been any changes or improvements with respect to what you learned from the pilot?
We made 4 particular changes in the protocol from the pilot learning that we actually moved into the RCT. So now we include patients who present in VT as well as patients who present obviously in VF. If a patient presents in VF and they're randomized to the double sequential arm, we keep them in standard care until a second defibrillator comes, and we actually adjust for that. The biggest thing though was really the fire shock piece, because what we've seen in the RCT to date is that we've had 34 patients actually randomized who had fire shocks first, And the changes you see in the pilot are minimal compared to what we're seeing in the RCT by including fire shock. So it really made a big difference to do a pilot study.
Really interesting. A question actually just from Ian here. Will the pilot cases be analyzed in the main study?
I didn't catch it.
Will the pilot cases be analyzed and included?
Yes. And that's the key of an internal pilot. The beauty of an internal pilot is you're actually using that data in the randomized trial. It'd be a shame to throw away 152 cases that are so well done, which differs from run-in data, which is oftentimes excluded from randomized controlled trials.
Fantastic work, Sheldon. I'm sorry we're out of time and we've got to keep things moving.
Yeah, thank you so much, and really appreciate it.
Thank you very much. Our next presenter, Mr. Brenton Wong, he is a fourth-year medical student at the University of Ottawa. Prior to medical school, he completed his Bachelor of Health Sciences honors degree at McMaster University. He's interested in emergency medicine, clinical research, and medical education, all things that I like as well. His current research interests include cardiac arrhythmia management in the ED, with a particular focus on acute atrial fibrillation and flutter. Brenton will be presenting his abstract, Thromboembolic Events Following Cardioversion for Acute AFib and Flutter, a Systematic Review and Meta-Analysis. Go ahead, Brenton.
Thank you very much, Dr. Yan. It's a pleasure to be here this evening to present our systematic review and meta-analysis. So before we begin, I'd just like to acknowledge all the co-authors on this study for all of their work and time on this study, which was conducted at the University of Ottawa. We have no conflicts of interest to declare. So acute atrial fibrillation and flutter are the most common arrhythmias that are managed in the emergency department. And for those who present with episodes with an onset of less than 48 hours, there's been a recent shift towards early cardioversion, discharge home, and prescription of oral anticoagulation for patients with risk factors for stroke. And within the literature, there's been a low theoretical risk of thromboembolism, as demonstrated in several short-term observational studies. However, recent studies have presented some concerning data on the safety of cardioversion. And together, these have led to various different amendments in major society guidelines with regards to OAC use in the post-cardioversion period. These have been given Class 2B recommendations according to the grade system. So the 2018 CCS guidelines recommends that all patients who undergo cardioversion receive at least 4 weeks of anticoagulation in the post-cardioversion period. Contrast that to the 2019 American Heart Association guidelines, which states that patients who have a CHADS-VASc score of 0 in men or 1 in women may omit post-cardioversion anticoagulation. The most recent 2020 European Society of Cardiology guidelines suggest that patients who present with a duration of AF less than 24 hours and have a very low stroke risk can omit post-cardioversion anticoagulation. So in the context of these weak recommendations, the objective of our study was to evaluate the effect of OAC use on thromboembolic events following cardioversion of low-risk acute atrial fibrillation and flutter. We specifically wanted to compare OAC use to no OAC use with respect to thromboembolic events at 30 days. So our study was conducted in accordance to the PRISMA and CHARMS guidelines, and the study was registered on Prospero. We conducted a librarian-assisted search of Embase, Medline, and Cochrane from inception to February 6, 2020. And we included observational studies, case series, and randomized trials reporting thromboembolic events at 30 days following cardioversion. The primary outcome was stroke, TIA, and systemic thromboembolism at 30 days following cardioversion. And for those studies that were included, we used the Quality and Prognostic Studies tool, which is a tool that assesses studies according to the 6 domains listed here and grades each domain as having low, moderate, or high risk of bias. Studies that had low risk of bias in 4 or more domains were considered to be of high quality. In terms of our analyses, so we generated forest plots, and these were stratified according to study design. The primary analysis of our study compared thromboembolic events based on OAC use versus no OAC use for studies deemed to be high quality. And our secondary analyses looked at thromboembolic events based on high versus low baseline thromboembolic risk, as well as the duration of arrhythmia onset. Those who had low baseline risk had a CHADS-2 score of 0 or a CHADS-VASc score of 0 or 1. and those with higher CHAD scores were considered to be of high baseline thromboembolic risk. So we screened a total of 712 abstracts, of which 74 full texts were reviewed and 15 full texts were included. Upon reviewing the reference list of these included studies, we did identify 5 additional studies that were included, leaving us a total of 20 studies included in the systematic review portion. Of the 20 studies, 8 of them were prospective cohort studies, 8 of them were retrospective cohort studies, and 4 of them were randomized trials. And of these 20 studies, 12 of them reported thromboembolic events stratified according to OAC use versus no OAC use. When these 12 studies were assessed using the QUIPS tool, we identified 7 studies that were considered to be of high quality, meaning they had 4 or more domains that had low risk of bias. And this included 4 prospective studies as well as 3 retrospective studies. Our primary analysis was conducted on these 7 studies of high quality. And you can see the forest plot here demonstrating thromboembolic events at 30 days post-cardioversion. We compared OAC use to no OAC use, and we generated a pooled relative risk such that a relative risk of less than 1 favored the OAC group, and a relative risk greater than 1 favored the no OAC group. And we found that there was insufficient evidence to provide certainty regarding the effect of OAC use on thromboembolic events at 30 days post-cardioversion. However, we did note that there was a low thromboembolic event rate post-cardioversion in both groups. As you can see here, there were 3 events out of 1380 cardioversions in those who received oral anticoagulation, compared to 6 events out of 1788 cardioversions that did not receive OAC. And I also want to point out that of the prospective studies, there were no events out of 783 cardioversions. In terms of our secondary analyses, so this was conducted on 13 studies that reported thromboembolic events based on high versus low baseline thromboembolic risk. So we compared those with high risk versus low risk. And just to remind you kind of what the definition of high risk as well as low risk was. And we found that there was more than a 2-fold increase in the risk of thromboembolic events at 30 days for those who had a CHADS 2 score greater than or equal to 1, or a CHADS VAS score greater than or equal to 2. So our primary analysis of 7 studies deemed to be high quality found that there was insufficient evidence to provide certainty regarding the effect of oral anticoagulation use on thromboembolic events at 30 days. However, it does appear that the rate of thromboembolic events post-cardioversion in contemporary practice is low, irrespective of whether OAC is implemented or not. We also found that higher CHADS 2 or CHADS VAS scores can greatly increase the risk of thromboembolic events following cardioversion. There were several limitations with our study. So the fact that there were so few thromboembolic events in both groups, even when pooled together, made it very difficult to evaluate the true effect of OAC use on thromboembolic events. We also found that a large proportion of the eligible studies for our systematic review had a high risk of bias according to the QUIPS tool, and this limited our primary analysis to only 7 studies deemed to be high quality. We were also unable to find sufficient data with respect to the duration of arrhythmia onset on thromboembolic events. In terms of how we move forward from here, so within the week recommendation provided by major society guidelines, the decision for OAC use following cardioversion should be a patient-centered one, as current evidence does not provide clear guidance on OAC use. Therefore, clinicians should consider both thromboembolic risk as well as bleeding risk when deciding to implement 4 weeks of oral anticoagulation following cardioversion. However, our study did demonstrate a low event rate, and this should help provide greater reassurance for patients who choose not to elect to undergo 4 weeks of OAC use following cardioversion. The fact that there was insufficient power to determine the true effect of OAC use despite pooling of studies indicates the need for additional high-quality data, both in the form of prospective as well as high-quality retrospective studies. And we hope that additional studies will also assess the impact of the duration of arrhythmia as well as baseline comorbidities and how they relate to thromboembolic events as well. So in summary, primary analysis in our study of 7 high-quality studies demonstrated insufficient evidence regarding the value of OAC use on thromboembolic events following cardioversion of low-risk acute atrial fibrillation and flutter. However, we did find that the rate of thromboembolic events post-cardioversion in contemporary practice is very low, whether OAC is used or not. And within the context of a weak recommendation as provided by major society guidelines, we hope that our study can help to better inform patient-centered decision-making when considering 4-week use of oral anticoagulation in the emergency department. And we'd just like to acknowledge all the research staff at the University of Ottawa for their contributions to the study. Thank you, and happy to take any questions.
Fantastic work, Brenton. We do have a couple questions from the audience. First one, were all the studies similar in terms of use of anticoagulation prior to cardioversion? Or did they even report on that?
Yeah, so in terms of classifying patients as in terms of like OAC use versus no OAC use, we classified patients on OAC use as either started on anticoagulation after cardioversion or patients who were previously on OACs before cardioversion and continued afterwards. In terms of the question, like how are the studies different? So there definitely was differences in the studies in terms of not all patients were on anticoagulation before cardioversion and some of them were started, but we did our best in terms of trying to group together and making this definition when we were conducting our review to make sure that we were capturing both the patients who were on anticoagulation and those who did not receive any prior to or after cardioversion.
That's great. A second question, Brenton, in your analysis, did you pool data from different study designs? Could you do that? And if so, how would this have affected your results? It's a little bit of a methodological question.
So yeah, we did pool. So we did stratify them according to study design initially, but we were able to generate like a pooled analysis because we essentially just took the number of patients who were cardioverted from each individual study. And then we took the number of events at 30 days. And we were able to basically generate event numbers for each different study. And we pooled them together. And with the help of our biostatisticians, we were able to get a pooled analysis, combining this data from all different studies, irrespective of study design.
Thank you, Brenton. We need to move on, but thank you so much for your presentation. Great work.
Thank you very much.
Our final presenter is Dr. Catherine Varner. Dr. Varner is an assistant professor and clinician investigator within the Division of Emergency Medicine, Department of Family and Community Medicine at the University of Toronto. She's also a clinician scientist at the Schwartz-Reisman Emergency Medicine Institute at Mount Sinai Hospital in Toronto. She's also a member of the Ontario Neurotrauma Foundation Guidelines and Concussion Clinic Standards Committees, and also conducts research in pregnancy complications in the ED. Catherine will be presenting a randomized controlled trial comparing prescribed light exercise to standard management for ED patients with acute mild traumatic brain injury. Take it away, Catherine.
Thanks so much, Justin. And thank you for everybody for hanging on for this last presentation. And thank you to CAEP for the opportunity to present virtually, as well as supporting emergency physicians throughout the pandemic. And I think I'm having the same difficulty. There we go. Okay, so I have no conflicts of interest to disclose. Funding for this trial is provided by the Workplace Safety and Insurance Board of Ontario, as well as a CAEP Investigator grant several years ago. And this protocol was presented at the NICER meeting in 2017, and I would encourage any junior investigator to attend NICER this year. It's taking place virtually in February. The emergency department is the first point of healthcare contact for most head injured patients. And the majority of these patients will not have intracranial injuries, but will go on to be diagnosed with a mild traumatic brain injury, also known as a concussion. And while most of these patients will have complete symptom resolution within a week, upwards of 30% of patients will develop persistent concussion symptoms. And 20% of these patients will not have returned to work a year after their injury. Current treatment recommendations for mild traumatic brain injuries suggest a period of cognitive rest and graduated return to usual activities. And patients are only encouraged to resume normal activities, including exercise, once symptoms have abated. And these recommendations have made dogmas like rest is best and when in doubt, sit it out, be quite pervasive in concussion management. However, recent studies are suggesting early exercise may have favorable effects on the injured brain, especially if it's initiated early after the injury. The objective of this study was to determine if adult patients presenting to the ED with a discharge diagnosis of acute mild traumatic brain injury prescribed light exercise are less likely to develop persistent symptoms at 30 days compared to standard discharge instructions. This was a multi-centered randomized controlled trial that was conducted in 3 academic emergency departments. It was Hamilton General Hospital, Hamilton Juravinski Hospital, and Mount Sinai hospitals. Each of these hospitals has annual emergency department visits around 45 to 65,000 visits per year. And the trial was registered with clinicaltrials.gov, and ethics approval was received from each of these institutions. All adult patients presenting to the ED with a mild traumatic brain injury sustained within the preceding 48 hours were eligible for enrollment. An acute mild traumatic brain injury was defined by the Zurich Consensus Statement, and the exclusion criteria are listed here. And diagnosis of mild traumatic brain injury and determination of trial eligibility were based on history and physical exam, examination by the attending physician. Informed written consent was obtained from research personnel when they were available, and when it was out of hours, or if the research personnel were not available, it was obtained by the attending physician. Using 1-to-1 allocation and block sizes of 4 sealed sequential envelopes, participants were randomized to either discharge instructions prescribing 30 minutes of light exercise daily, or discharge instructions describing graduated return to usual activities and cognitive rest. The discharge instructions were read by the attending physician or treating nurse. Patients were also given a printed copy of the discharge instructions, and these were adapted from the Ontario Neurotrauma Foundation guidelines for the management of mild traumatic brain injury. The control group received instructions that specifically described graduated return to usual activity, but they were instructed to not return to exercise until their symptoms had resolved, or if they were advised to do so by a medical provider. And the intervention group received the same graduated return to usual activity instructions, but they were advised to participate in 30 minutes of light exercise a day after a period of relative rest for 48 hours. They also received a prescription that looked like this that advised the same thing. So 30 minutes of light exercise daily, up to 5 times a week. And they were, if they were experiencing symptoms such as severe headache, dizziness, or generally feeling unwell, they were advised to stop exercise. The primary outcome was the proportion of patients with persistent concussion symptoms at 30 days, and this was defined as the presence of 3 or more moderate symptoms on the River-Mead Post-Concussion Symptoms Questionnaire. The analysis of the trial is very straightforward. Proportional differences of PCS between groups were assessed using Pearson chi-square statistics, and differences in RPQ at 7, 14, and 30 days post-ED visit between the intervention group and control groups were compared using sample t-tests. And all of the analysis were conducted according to an intention to treat principle. Based on prior studies, we predicted 30% of the control group would have PCS at 30 days. And assuming an alpha of 0.05 and a beta of 0.2 to detect a 15% absolute risk difference, we estimated that 236 participants were needed to be enrolled to reject the null hypothesis. And to account for potential attrition, we increased the sample size by 25% and planned study enrollment for 296 patients, or 146 in each group. The recruitment period was from July 2017 to October 2019, and the study ended when the target sample size was met after accounting for study attrition and all participant follow-up time points were completed. A total of 367 patients were enrolled in this study, and 184 were randomized to the control group and 183 to the intervention group. The median age was 32 years and 57.6% were female. Patient demographic and clinical characteristics were similar between groups. And the only notable differences were being the incidence of direct impact injury or being under the influence of drugs and alcohol at the time of the injury. The clinical characteristics such as history of headaches, depression, and concussion were also similar between the groups. And this cohort notably had high rates of mental illness and drug and alcohol use. And overall, the baseline RPQ was 15, which correlated with moderate head injury symptoms. And at ED presentation, median pain scores were 5 on the visual analog scale, and 85% of participants reported headache at the time of their ED assessment. The main finding of this trial was that there was no difference in the proportion of patients with persistent concussion symptoms at 30 days. 13.4% of the control group and 14.6% of the intervention group met criteria for persistent concussion symptoms at 30 days, but this was a non-significant difference. There were also no differences in secondary outcomes between the groups. There were no differences in median change of RPQ scores, median number of return visits to healthcare providers, median number of missed school or work days, or unplanned visits to the emergency department within 30 days. It is, however, important to note that participants in the control group reported fewer minutes of light exercise at 7 days, which was a relationship that persisted at 14 and at 30 days. And fewer participants in the control group reported participating in physical activity within 7 days, but this trend did not persist at 14 or at 30 days. We recognize our study has several limitations. It was conducted in a small number of study sites that were all urban and academically affiliated, which may limit the generalizability of the results. There was also a high rate of attrition, but both groups were equally affected. And in addition, the average patient enrolled in the study presented with moderate head injury symptoms, which suggests we may have enrolled lower acuity MTBI patients. The participants were also not blinded to treatment, thus intervention bias was possible. And additionally, patients may have sought medical treatment from other healthcare providers and may have gotten conflicting advice from what was given to them in the emergency department. And finally, the primary outcome measurement was using RPQ, which is a self-reported and a subjective measurement of symptoms following MTBI. So to our knowledge, this is the first randomized trial of prescribed early light exercise for adults with acute MTBI. There were no between group differences in recovery or healthcare utilization outcomes. And an exercise prescription is simple. It was not harmful for this patient population and has demonstrated efficacy in other injury patient populations. But an exercise prescription is likely not sufficient to prevent persistent concussion symptoms. But our results suggest that prescribed early light exercise may be encouraged as tolerated at emergency department discharge following mild traumatic brain injury. So I just would like to say thank you to the co-investigators that worked with us on this trial. Kristen DeWitt was the site PI in Hamilton, and Shelley Reeves and Cameron were based in Toronto. And they were just such a persevering team. I always say that doing research is like swimming in mud, and I couldn't imagine swimming with better people. And I'd like to thank our departments for allowing us to run this trial in the department and in all 3 departments, because as you know, doing research in a department can at times be quite disruptive, but so helpful for the advancement of science. Thanks so much.
Thank you, Catherine. Excellent work. We do have a question from the audience. Did you find any difference between male versus female participants, and if there was any influence with age as well?
So we haven't analyzed specifically based on those characteristics, but I think that's an excellent question to ask.
Second question for you, Catherine. What do you think was the impact of attrition on the study outcomes?
Well, we know that the groups, we lost patients to follow up in both groups. And so it's hard to say exactly what the outcome, we obviously don't know what the outcomes of the patients whom we failed to follow up. And so we are looking to doing best case and worst case scenarios on that patient population. But at this point in time, we don't know.
And what's your kind of bottom line takeaway from this trial about the care of MTBI patients in the ED?
I think our bottom line is that there are a few things that we noted about our patients in this trial is that the vast majority did not follow up with any healthcare providers after emergency department discharge. So what we tell them is very important to their management, certainly in the early days following head injury. And I think our takeaway was that providing an exercise prescription was safe. For the patients that were enrolled in the study, it did not have a significant impact, but it did not appear to be harmful. And so we are encouraging groups to encourage exercise prescriptions following MTBI.
Fantastic, Catherine. Thank you so much for your hard work and for sharing your presentation with us. Well, very well done. Just final thoughts. This concludes our presentations for this evening. And again, a big thank you to all of our presenters, as well as Jeff Allen for his IT support, Christina at the CAEP head office for organizing, as well as Kelly and Shanna for their hard work for the abstract competition. I just wanted to invite you all to our next CAEP National Grand Rounds on Wednesday, November 4th at 7 p.m. Eastern Time, entitled Towards Equity, Diversity, and Inclusion, the Start of the Conversation. It looks like it's going to be a fantastic talk with some great speakers. We hope to see you all there. Thank you so much, everyone, for attending. Enjoy your evening, and please stay safe and healthy.